So due to the time limit, let's close the first session. Now let's move on to the second item on agenda. Please allow me to give an introduction to Director Wu Zhen of our center. He is a renowned surgeon nationwide and worldwide for pancreatic surgery, and the floor goes to Professor Wu Zhen. My topic today is about our center's practices for pancreatic surgery, as well as our development, my observations. So it is such a great honor to be joined by so many international friends and domestic specialists to participate in this event. We also hope we can have the opportunity to invite you to Xi'an so that we have a in-person exchange. You may know that many people know that Xi'an is a famous ancient city of China. Like more than 1,000 years ago, it became the capital of China, including Qing, Han, Sui, Tang dynasties. In these influential dynasties, the capital was set up in Xi'an. So that's why this Tang poet Du Fu mentioned that since ancient times, the dynasties are always set up in Xi'an. That is to say, Xi'an has a very important geographical location. More than 138 BC, Xi'an started to construct the Silk Road. That is a road for commercial exchange, cultural exchange. It's a road of friendship. And also Xi'an is the new starting point of the Silk Road economic belt. And now relying on the benefits of the express China-European train, we have established this very good transportation network. And Xi'an accounts for more than 30% of the Belt and Road trade nowadays. And Xi'an is determined to strengthen international medical cooperation. And during the Mid-Asian Forum recently, we have 38 medical institutions serving the patients in Middle East, in Middle Asia. And also we have established friendship ties, sister city partnerships with 26 cities, and also we have thousands of Central Asian students, and we have established a lot of people cultural exchange ties. So Xi'an has become a very important city for Eurasia cooperation, and it has this transportation advantage, and also we have the openness, we have this cultural background, we have sci-tech innovation spirit. So welcome all of you to come to Xi'an for academic exchange, and you can do for sightseeing here, and we will receive you with hospitality. So let me give you a brief introduction to the development of our department of pancreatic surgery at our hospital. This hospital was established in 1956. And then the second year, our hospital performed the third Whipple procedure in China, and the first one in Western China. And also it has been reported nationwide. And in the 70s, we reported long-term survival cases of pancreatic body and tail cancer and insulinoma. Back in 1985, we established the hepatobiliary surgery department as an independent department. In 1997, our team was awarded the second prize of Shanxi province for high-tech progress. In 2008, we established the pancreatic surgery board, just now mentioned by Professor Wang Zhen. In 2022, we further segmented this discipline. So since 2022, we have further fine-tuned or segmented this. So in the past, we mainly did a lot of hepatobiliary surgeries, but after 2026, we no longer perform liver surgeries. We reassigned this to other wards, and now we focus on pancreatic surgeries, including inflammation, tumors, and so on. And then in 2011, we established China's first ever multidisciplinary team for pancreatic disease diagnosis and treatment. And we also had a lot of debuts, a lot of presentations in academic seminars of China.
Afterwards, we were being approved as the training base for endoscopic surgery by NHC, National Health Commission. With this endoscopic surgery are designed for the pancreas and bile duct and for this area. Also in 2017, we established the collaboration center for the treatment of chronic pancreatitis microsurgery treatment. In 2018, we were approved to be the key subspecialty by the Ministry of Health by the country. And also we got the award, second award for the tumor treatment progress award. In 2019, we got an award, first award from the local province. And in 2020, we established the diagnostic and treatment center for pancreas diseases within Xi'an Jiaotong University. And in 2023, we become the only national pancreas tumor treatment quality control center. And then moving to last year, we have built MDT collaboration with many pancreas treatment center around the world. At the moment, for our organization, for the ERCP treatment, we complete 400 annually. In terms of the endoscopic surgery, we have the ultrasound diagnosis. Each year, we can have 800 EUS, and about 500 or 600 is actually facilitated with the catheter or percutaneous catheter drainage, facilitated by the CT and ultrasound. Also, we have completed 150 VARD treatment annually for the acute pancreatitis, and 300 Whipple procedures and 300 distal pancreas dissection. For the Whipple surgery, 50 to 60% of the recovery are being done by robotic surgery and laparoscopic surgery. For the DP, 300 DP, most of them, 80% of them are actually laparoscopically. We also have 50 cases of MP and other types of the procedure. Over the years of development, well, moving back to today's topic, now we started from a department for liver, bile duct and pancreas into a specialized pancreas treatment department. We have received more and more of the cases. Now we are thinking about how do we improve the quality of our services. Therefore, that means we need to do a lot of the trade-off. In some of the hospital departments, well, some of them, they actually resort to the approach of expanding the indication for surgery for patients to increase the number of surgery. Well, we don't think that's the right way to go. We think when we are performing surgery and trying to trace the number, we also need to also have a quality of our surgery to be improved, so that surgery needs to be indicated for certain diseases and certain staging of the diseases, and also surgical skills need to be improved itself. Now, for our cases, well, we are, as a physician, as a surgeon, we are often faced with a choice between having a surgery or a follow-up. Well, if the patient have the criteria of less than 1 centimeter of a PNET, then we can go with the surgery. But according to the difference of the PNET, if it's less than 2 centimeters, or if it's higher than that, then the rationale for surgery will be very different. At the moment, as a surgeon, some of the surgeons, they actually do not take this criteria seriously. For the PNET less than 2 centimeters, some physicians or surgeons, they opt for surgery, but some opt for follow-up. The practice is different worldwide. We don't have a consensus worldwide. Now, we also need to choose between standard or classic Whipple. And for the tumor invasions less than, for example, 2 centimeters, we can resort with a exenteration that will be providing a longer benefit for the patient, because for the less than 2 centimeters, this patient, when resorting with the exenteration, they can have a longer benefit because the tumor growth will be slower. I think we need some multi-center cohort observation so that we can get a better answer for that. As for other types of the pancreatic tumors, for example, pancreatic cystic tumor, we also have the issue of over-treatment. Well, for different typing of the tumor, sometimes it can be cystic type, and sometimes it can be other types like, for example, liquorous type. The treatment or surgery will be different. for the different subtyping of the pancreas, well, with different PNET sizes, they will have a different surgery options. So, for example, if we have a local invasive pancreatic tumor, we probably will first opt for the local resection, but that in itself probably is not sufficient. We also need to combine with other treatment measures, such as pain management. In Chinese patients, we found that most of our patients suffering from pancreatic tumors, they don't experience a lot of the pain. Compared with the Western countries, the patients mostly have an issue of pain management. And that also relates to the earlier involvement or early treatment of the pancreatic drainage by the means of a percutaneous drainage, so that we can relieve the pressure in the pancreas to avoid a rapid progression of the pancreatic tumor and other diseases like pancreatitis. Now, so for surgery, we need to think about the selection between surgery and the endoscopic one. For example, for recurrent pancreatitis combined with a pancreatic duct stenosis and abnormal biliary pancreatic union, those are mostly younger patients. We need to think about whether we use IPMN combined with the recurrent pancreatitis. We surgeons need to think about the option, whether it's an open surgery or the endoscopic one. Other indications are listed here, such as chronic pancreatitis combined with pancreatic duct stones. Well, for this, we need to think about pain management for the patient. As for the last one, pancreatic pseudocyst and peripancreatic ward of necrosis, we need to think about percutaneous catheter drainage and debridement. Well, in each indication for surgery, we need to think differently. I think MDT can be very effective to get and arrive at an ideal solution. Well, as Sackert mentioned in the previous presentation, that the surgery development in the pancreatic treatment or tumor has evolved rapidly. Now, well, we need to balance safety evaluation as well as the therapeutic efficacy in terms of the surgery. Well, when there is when the risk-benefit ratio is not in favor for surgery, well, we need to rethink about the option of the surgery. I know there are many randomized controlled trials conducted in Europe, and they are producing quite good outcome. Well, we hope also we can work with them for better and scientific evaluation of different types of the treatment, of surgery treatment. Now, next part is on the thinking between the radical surgery and also the palliative surgery for the different cases. we listed a number of the indications for surgery and also the consideration for selection of a radical and palliative surgery. For each and every case, we need to analyze deeply and have an individual-based selection for surgery or other different types of treatment. When it comes to palliative surgery, we also need to talk about the tumor clearance rate. Well, do we need to do it 70% or 90% for the palliative surgery? This is something we also need to build a standard. At the same time, we need to think about other scenario. For example, the locally advanced pancreatic cancer and patients also with the percutaneous catheter drainage. So normally we will start with the percutaneous drainage for the patient with a local involvement. Then we will opt for the other types of the treatment and surgery.
So we should consider the success rate of conversion to chemotherapy, and also whether we would lose the opportunity of a surgical operation. We should think about this, and we should gather statistics from different centers, and then we summarize, and we can reach some consensus. Recently, we've seen newly published papers mentioning for peanut over 2 centimeter and the pancreatic cancer without invasion to the splenic ileum. So they try the preservation of pancreatic belly and tail. So this is an attempt. We have not been performing that at our center, but we see an increasing number of reports of literature. So we will continue to explore this for peanut over 2 centimeter. So we may be diagnose the patients with solid biliary thyroid carcinoma, and if they perform the surgery, they have the surgery, and we will have a long-term observation of the prognostics. So, and we will find out whether there is some contradiction with the peanut over 2 centimeter guideline. So whether we should reserve the spleen or tail or whatever. So that is also my confusion. And lastly, I want to talk about the methodology. First, I believe we should always trace back to the source, and we should always stay true to our mission. We should never forget why we started, because we should always try to benefit the patients instead of showcasing our techniques or new thinkings. So it takes practice. We need to practice more, and also we see that new technology is coming to being because they are breaking consensus, because they are not conventional. We should also acknowledge that. And also we should follow several principles like multidisciplinary discussion. We should discuss with different disciplines for each case at an early stage, and we discuss, and then we agree on the best therapy for the patient. And also we should have this IIT, or investigator-initiated clinical studies. Like we have this multi-center in China and abroad. We have this randomized control studies to find answers to these questions. So I believe tonight we are joined by so many colleagues, and I think more or less you have pondered the questions I just raised. So I'm eager to know about your ideas, your perspectives of these questions. So this is my presentation today. So it's about my observation and some experience from our center. Thank you, Professor Wu. Thank you for your thought-provoking presentation. I think in our work, we are continuously thinking, pondering these questions, and I believe we will get more inspirations. Also, I believe we'll get some suggestions about the next steps. So according to our agenda, Professor Wei Yuan will guide our discussion or panel discussion.
Thank you for the lecture from Professor Zheng, and it's very delighted to have a very detailed thinking about the pancreatic surgical procedures, about the problems and the changes in the pancreatic surgery field. So next, I want to invite the professors to have a comment on it. And first, I want to invite Professor Inoue. Hello, Professor Inoue, are you there?
I'm here.
Yep.
Yeah. Thank you, Professor Wu, for your so concise and really clear summary of challenges in our field. And yes, in our opinion, and the most curious point is how we can increase the conversion rate in the initially unresectable pancreatic cancers. But the most important point would be to prolong the prognosis, not just to increase the resection rate. Our final goal is the improvement of overall survival. So the most important point would be the effective and sustainable induction chemotherapy, systemic. And another point would be the establishment of a formal and comprehensible criteria for conversion surgery. And as the Professor Wu mentioned, we should divide the unresected pancreatic cancer clearly to the locally advanced and metastatic. And in our opinion, metastatic pancreatic cancer should be further divided into potentially convertible or, how can I say, the hopeless cases. So our next step or our next discussion will be how we can analyze the important factors to establish some criteria. To be honest, we have already established ABCD criteria, which was described in the British Journal of Surgery last year. So please refer our papers. Maybe I can share with Dr. Wei via emails. So please share it too. But I want to know all the Chinese doctors' opinion based on their tremendous volumes. Yes, it's my comment. Thank you.
Thank you. Thank you very much. Thank you very much for your very, very good advice and suggestions. And we can get in touch more by emails for this topic. And then I want to invite Professor Giovanni Marchigingiani. Giovanni, are you there?
Yes, I'm here, even though my connection probably is not so stable to make a comment now.
Yeah. So what's your advice and suggestions for the Professor Zheng's topic?
Yes, I think I agree with Professor Inoue in what he said. It is now mandatory to analyze, the new techniques and biomarkers that we have. We need to have more a biology-based approach. I mean, we as surgeons can now achieve amazing results, but we always have to keep in mind that the disease we are fighting, they have a very strong biology. So only in selected cases and only by novel techniques, including new DNA analysis and biomarker, will lead us to better results in this journey. Thank you very much.
Yeah, thank you. And then for the Professor Bias Kahan from Mongolia.
Oh, thank you very much, all professors and participants. It's very nice meeting. Thank you very much.
And so, do you have any questions and comments on it?
Oh, no.
Okay, thank you.
Okay, thank you.
Yeah, and then for the invitation for the Professor Christine Gatzil from Board Zero. Hello, Professor, are you there? You are mute now. You need to click on mouse button.
Trying to. Yes, thank you so much. It's a very good talk, Professor. And just a minute, I will take a note to make a question. Just a second. Yes, here. Professor, how do you manage, Professor, patients with borderline resectable disease who demonstrate early chemoresistance? And do you advocate for alternative local regional therapies or inclusion in the trials? That's it. Thank you. Thank you for the experience.
Okay, thank you. And then, so we just
about this borderline resectable disease. So because our team is in charge of this biopsy, after we got the result, we had two chemotherapy approaches, including AG and Firox. And our conversion rate is not very high. It's like a little bit higher than 20% conversion. Many patients may have their symptoms progression during this procedure. But our principle is that after 4 or 6 weeks of chemotherapy, if there's no progression or advancement, we may reevaluate for surgical operation, for surgical procedure to improve the surgical dissection rate. And for some patients, after the resection, we can see from the specimen like that's the 2-1 resection. For this kind of patients, we may have radiotherapy plus chemotherapy. So we use this conventional chemotherapy approaches. And there are some clinical studies where we included some of China-produced targeted drugs. It's called Savantini, to transliterate, but they did not have very significant improvement.
Okay,
thank you, Professor.
Thank you for Professor Wu's answer. And then here we need to invite for our very famous professor and Professor Ma Zhenghua from our team.
I really appreciate Director Professor Wu's introduction to our pancreatic team. Just now, I listened to the presentations, insights, and motivations from experts worldwide. I really agree with Professor Yosuke's idea about the pancreatic cancer treatment. For pancreatic surgery, for the cancer surgery, I think it's near perfection already. And for a mature surgical team, the surgery involves a certain scope, and so want to control the scope. And within this scope, we can achieve relative safety and satisfaction for the patients. So under such circumstances, we should consider how can we do the certification to achieve better results. Like for this dissectable cases, we can have this kind of we can use surgery as our first response. And for the borderline resectable or locally advanced cases, what should our approach or strategy be? So like for this multiple liver metastasis and multiple metastasis, we'll consider whether surgical operation can achieve good results, because many people are doing groundbreaking work, and we need to think about that. In this regard, we can have a multi-center studies, like involving different races, different ethnic groups, different localities. Also, we can explore the drug sensitivity, like just mentioned by Professor Christine. Our therapy strategy now is that we use this kind of resolvent medicine for clinical study, and we are waiting for a further observation of the actual therapeutic effects. And for China, we are thinking about we will do a similar approach to liver cancer. We'll do some immunotherapy, but so far the effect is not so good.
So first one is a classification of the pancreatic cases. Now, for us, we need to first of all develop the patient treatment strategy based on the classification of the stages, differences, and also the different aspect of the tumor.
I'm sorry, and my video, sorry. Yes. Thank you very much for your presentation. I have one question. When you presented your department, you mentioned that you perform nearly 150 ward procedures annually. Which cases you perform it? This is after, during complication after Whipple procedure or in other cases? Thank you very much. You know?
For the 150, that's a VARD. VARD. Well, I think it's called video assisted surgery. That's for the acute pancreatitis treatment. It's a video assisted retroperitoneal debridement. Yeah.
Just for acute pancreatic necrosis. You just. Okay, thank you very much.
We have a Professor Yang Xie, who is involved in the chronic pancreatic treatment. Or Professor Yang Xie. Thank you for the introduction, dear experts home and abroad. Good evening. I am very happy to be here so that I can exchange with our experts. Now, just then, we have two speakers, Silo Hackert and Professor Wu Zhen. learned tremendously. And I also saw Professor Inu from Japan. Now, taking this opportunity, I want to ask one question. My question is, in Japan, what are the incidents of the pancreatitis progressed to pancreatic tumor? Now, we also have the early intervention for pancreatitis treatment to prevent progressing to the tumor stage. Do we also have the early stage involvement or intervention like surgery to make that it's not progressed to the tumor? Now, in our hospital, we are also actually having the transition when patients have symptoms. For example, in the first 3 months, when we have the not favorable outcome or for the one kind of surgery, we will also switch to other better surgery options.
Okay. Maybe your question is development to the pancreatic tumor means pancreatic neoplasm, like cancer, or tumor forming pancreatitis or ward of necrosis, right? Which originally the benign pancreatitis. Maybe I cannot. Yes, and the instance of cancer carcinogenesis. Do you mention? Yeah. Mm-hmm. 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 Okay. Yeah, I'd like to say that I don't have much experience about the treatment of pancreatitis because my affiliation is a Cancer Institute hospital, cancer-specific hospital. So we do never perform the big operation or fray operation for chronic pancreatitis since symptomatic. But in general, in our society, the instance of chronic pancreatitis is quite lower than Chinese society or other Western countries because of the way of eating or dietary habits. So maybe in the in a future session we can invite some specialists of pancreatitis in our society. It's my temporary comment, so I'm sorry. Yeah. Mm-hmm. Mm-hmm. Okay. So you mean the instance of pancreatic cancer accompanied by the pancreatitis, right? In my impression, it's not correct data or well analyzed data, but in our impression, the proportion of chronic pancreatitis with stone is very, very low in pancreatic cancer patients. The most of the pancreatitis which are accompanied with pancreatic cancer is, so-called obstructive pancreatitis or, iatrogenic pancreatitis after ERC. So in both cases, we can manage it, but I imagine that the pancreatic cancer surgery with the chronic pancreatitis is much more tough and difficult to perform the precise cancer dissection. And maybe, Nadia, I want to learn from you, your society. Yeah. Yeah.
Now, in light of the time, we will conclude the second part. Dear friends online, we would like to ask if you have any question or comments to the presentation made by Professor Wu Zheng. Now, even though we will proceed to the next session, now, on behalf of the team, we'll start with the second part. Thank you for the introduction, and on behalf of the team, we will actually have a series of activities that falls in the scope of a PANWEST Pulse. Now today, this sharing is on right time and situation making the PANWEST Pulse. I am Han Liang. Just then, we have the sharing from Wu Zheng. Well, Wu Zheng make a lot of contribution and sharing on the history development of our department. Now this PANWEST Pulse platform is born in the new era. I think in this era, we have a very advanced network and we have a booming academic exchanges. And in this era, we have the need for international communication. At the same time, we need to make a breakthrough in our discipline. Just like Professor Wu Zheng mentioned, there are many controversial things in the pancreas treatment, and we need to explore more, which requires more sharing of the experts and more data to be collected, and as well as acquisition of more biological and medical data. Well, then we can have a better exchange. It is in such a background that we started the PANWEST Pulse. Another one is we need to address the common issues we face in the practice. There are some commonalities and differences. Well, experts from different countries, from different backgrounds, they can make their sharing and explore so that we can learn from each other. In this way, we can benefit the patients the most. This also is helpful for us to know better about the disease of pancreas. Now, for the pancreas diseases, or no matter for the acute one or the chronic one, as well as a different classification of the tumor, it is worldwide. However, in different countries, we have a different classification and understanding of the pancreatic diseases. Therefore, we need a global community to have a better exchanges. The purpose is that we can guide our work with the most advanced and scientific tool and standard. Now, PANWEST PAUSE aims to build a platform for foreign and Chinese practitioners to get together here. Now, we have a different background, but we have the same goal, that is serving our patients with their pancreatic diseases. For our team, we made a lot of preparation under the leadership of Professor Wu Zheng. Starting from last year, we have started with a case study compilation for the pancreatic diseases. This is a compilation of a very difficult and rare pancreatic diseases that is collected and to be shared. This way we can have a more standard development in the area. Another one is we are sharing some of the typical cases for exploration and discussion, aiming so that our patients can get better help and better treatment.
And thirdly, we can collect more experience of scientific diagnosis and treatment. So there is a lot of specialty, a lot of idiosyncrasy with this special disease, pancreatic tumor. So that need us to gather more experience, like related to the indoctrination, to neurosis, to cancer, to different categories. And also it's about cultural diversity. So we should share our knowledge and we should have this cultural diversity. That's why we established this platform called PANWEST PULSE. The aim is that we should ponder and explore the nature of pancreatic disease. This nature is very important. And secondly, the aim is to explore a scientific diagnosis and treatment system that is very comprehensive and that is all-inclusive, very sound. And also this platform serves as a channel for us to share our experience, our lessons with the domestic and national colleagues so that more patients can benefit from this work. So about our plans for PANWEST PULSE, first it's about the members. So it's many colleagues in the hepatobiliary pancreatic department in China or abroad. So it's in the high-end platform. So anyone who aspires to be part of us, so we welcome everyone. And the scope, the range is not only limits to the Belt and Road countries, rather we welcome global North, global South, Western, Eastern countries to be part of our framework. And we'll have a monthly session, like in the early or middle days of each month. Sometimes we'll have online seminars. Sometimes we'll also have in-person events. And the content or the details of PANWEST PULSE. First, we'll share theoretical knowledge because there's many very fast updates about pancreatic disease. So we can share the theories, especially cutting-edge progress or content. So that is of pivotal importance. And also we will share the techniques, we will do technique promotion. So it's not only about the surgical skills, but also it's about the thinkings and the disease, also exchange of notions and ideas and skill training or capacity building for medical students, etc. And third part is about clinical research discussion. We can have a lot of thinkings about clinical issues, and we can discuss the ongoing studies, our own studies, other research studies, or we can collab joint research. And next part is about the recap of some difficult procedures, like we'll have this multi-center surgery live broadcast. And while doing the live broadcast, we'll do some recap or review of the surgeries so that we can better avoid risks, and then we can ensure safety and radicality of the tumor surgeries. And also, we will try to dissect some difficult cases. I believe each center has our own difficult cases, so we welcome each center to share with us some rare difficult cases, like some kind of family-related pancreatic disease. So we can share these rare cases and we can learn from each other. So next part is about we can share our confusion about the fundamental research. We know that so all the fundamental research are oriented from clinical confusion or clinical problems. So we can share our observations about clinical work, and then we can find new topics for fundamental research. Also, it's about bringing medical services to the place where it is most needed. I think the nature of medical service is always patient first. So we want to channel high quality medical resources to where they are most needed. So this is the framework of PANWEST PALS. I hope as time goes by, as we collect more ideas, we can add more content to this PANWEST PALS framework. So this concludes my presentation. My name is Han Liao. I am from the First Affiliate Hospital, Zhuxie Jiao Tong University. For the interest of time, maybe we cannot share more details about PANWEST PALS future plans. I think this platform is urgently needed for us because we need to learn from our colleagues and peers home and abroad in the pancreatic surgery practices. There's a saying in China that if you like a baby, let the baby be a pancreatic surgeon because that's a very challenging and rewarding job. If you don't like a child, you can also send him or her to this department because it brings endless pains. So I think this reflects our mixed feelings about this department of pancreatic surgery. So for all these post-operative patients, they have a lot of complications, like 90-day mortality rate, incidence of complications is high compared with the general surgery. So that is because of the characteristics of pancreatic surgery. But during this procedures, the surgeons also enjoy some pride and a big sense of accomplishment, which other general surgeons may not easily obtain. So we have shared a lot of special cases and clinical study sharings and some of our observations and thinkings. We shared a lot. I believe this can gather more consensus and mutual recognition. And in the future, we can bring more patients with differentiated therapeutic strategies and methodologies. We hope through an event like this, we can gather together international and domestic colleagues. We can build up close ties for mutual progress. Also, we hope on this platform, we can have a lot of international multi-center clinical study programs so that we can finally reach some consensus. Like I just mentioned, there are some contradictions between the guidelines and actual practices, like the gaps between our aspirations and the reality, and some questions we cannot answer very clearly. We do not have enough data, etc. In the future, we can work together to find more data and support the revision and development of guidelines and consensus. I appreciate all the panelists, all the participants, especially Professor Dilo, Agat, and all the panelists, all the experts. I really benefited a lot from your insights. Very inspiring. I believe in the future, we will hear more from experts of different national or cultural backgrounds. We look forward to 1 month from now, where we can meet virtually or in person for another event. And in September, we'll have an in-person event, what we call a week of pancreatic treatment seminar. So if possible, you are very much welcome to join us in person. We appreciate the organizers. Also, we appreciate Professor Wang Zhen's contribution and efforts for this meeting. We hope in 1 year, we will see a more tangible fruits. We will see more personal and professional growth, and we'll see more multi-center studies delivery, and we'll see the building of more consensus. Thank you very much.
Bye-bye. Thank you.